Good afternoon, ladies and gentlemen. My name is Casey Hall. I'm one of the neurocritical care physicians in the Emory system, now over at Midtown more so. But I wanted to talk to you about post-cardiac arrest management. And really I was asked by the organizers to talk about a recent trial called the Princess Trial, which was presented in Chicago at the most recent AHA meeting, which apparently garnered a lot of discussion. So I was asked to talk about that and then sort of frame it a little bit within what we do currently. I have no disclosures to make. And at the end of this talk, I'd like that we could at least, or you could contextualize this particular trial within the overall data that we have on post-cardiac arrest management. What does it mean? What does it mean going forward? What does it mean for us at the bedside in terms of our practice? And then to describe the existing standard, that'll sort of be at the end, we'll talk about, again, framing this, but what is the existing standard and how does this change? Oh. Not sure what happened there.
This is where you had the question.
Say it again?
This is where you had the question.
Well, so what temperature do you or your institution use for post-cardiac arrest management? Just as an introductory question, do you use 32 to 34? Do you use 36? Do you use a range from 32 to 36? Or do you avoid fever, but you don't use target temperature management? Okay. So, yeah, I think this C being 71%, that is in line with the guidelines that exist, which we'll sort of talk about at the end. I do want to point out that 5% of folks avoid fever, which is a little problematic depending on how it's done, because we know that fever is associated with poor neurologic outcomes, and so if you wait until someone has a fever and then you treat it, you're often behind the curve and you're incurring negative outcomes until you get the fever down, back to fever. But we'll again talk about that at the end, because that comes up at the end, where we go from here. So we know that paradigm shifting occurred back in the early 2002 with the publication of two landmark papers, the Haka trial and the Bernard trial, which really set forth a standard of care for cardiac arrest or post-cardiac arrest management that occurred outside the hospital. These both demonstrated that 32 to 34 degrees for 12 to 24 hours led to improved outcomes, less death, and it has become the standard of care. And as we sometimes see after a paradigm shift, there are numerous questions that come about because of the new paradigm, new puzzles to solve. And we have seen over the past almost 20 years that there have been numerous investigations on what about shockable versus non-shockable rhythms? Does one population benefit from another? Well, what about in-hospital cardiac arrest? There have been numerous studies on in-hospital cardiac arrest. And does in-hospital benefit just like out-of-hospital? Does the duration of hypothermia or targeted temperature management, does that matter? Does 12 hours at a low end give you any benefit versus 24 hours, or 28 hours, or 48 hours, which a recent publication came out and looked at? What about the different types of cooling devices? In endovascular cooling, in which a catheter is placed in the vessel, versus surface cooling, like a great number of us do with either Arctic Sun or Cincinnati Sub-Zero, sort of blanketrol type devices. And so these are all puzzles that are being investigated, and we know that one of the biggest puzzles that has been looked at is the paper that came out in 2013 that compared 33 degrees as a target, which is sort of the standard of care, versus 36 degrees, which some people mistakenly called normothermia. 36 is not a normal temperature. It is hypothermia. It is less hypothermia than 33, and it must be controlled. And we know that the answer to this was that there's seemingly no difference in terms of outcomes between 33 and 36 writ large. We can talk, and last year I talked much more in depth about some of the details. We don't have time for that this year, but it's an interesting question. But interesting enough, if you go to the New England Journal of Medicine, where the TTM trial is, and you look a few weeks later at the inevitable comments that come out, there was an editorial that came out that was written by a fellow named Pierre Norberg, who said, well, wait a second, let's hold up. There are a whole bunch of problems with the 33 to 36 with the TTM trial. For example, it took 6 hours to get to their target temperature. Maybe that's not in line with all the data. They need to do it faster. If we got to target temperature 33 much faster, we would have much better outcomes. You know, don't put the cart before the horse. The thing about it was that he was actually conducting a trial at the time called the Princess Trial, in which they were looking at rapid onset of hypothermia. And that's what I was asked to talk about. But I wanted to ask you first, what's the biggest barrier? Wait a second. It should be at the end.
Yeah, they must have been out of order.
So I'm not sure. But we can maybe come back to this. How about that? Too much variability. We'll come back to this at the end, too. That should be the last question. Okay. So we've seen that when we think about some of these puzzles, we have, let's look at the optimal temperature, 33 versus 36. And then we have this question, what about the time that we achieve the target temperature? How fast is beneficial? And so that's what the Princess trial looked at, in which the aim was to determine the effect of intra-arrest initiation of target temperature management in the field. So EMS was actually initiating hypothermia in the field prior to the standard, which is when they get to the ICU. So if you think about a clinical trial, that means that they have to get to the patient, they have to make sure that there are no exclusionary factors, they have to enroll the patient and get the trial in the field while they're also resuscitating the patient. So that is a daunting task. And then the goal was to look at how do patients do in terms of their outcomes. And so our current clinical practice is what I described. Patient has an arrest and they get returned with spontaneous circulation. They get brought to the emergency department and then to the ICU, and at some point after they arrive to the hospital, either in the ED or in the ICU, target temperature management is initiated for a period of time, generally 24 hours. And then there's an outcome at some point. The Princess trial actually tried to move the temperature management, as I mentioned, much forward into the arrest setting. So a big sort of, not a paradigm shift in a sense, but certainly one of the puzzles pieces to be added to this picture of cardiac arrest. And so how they did that was that they used a novel device called the Rhino Chill. And the device is here. It actually goes into the nose, right here, and it sprays this cool mist that kind of cools down the blood flow around the brain, the sort of the sphenoid area in the brain, deep down, kind of cools it off. The pituitary is right there, target in terms of management of temperature. And that was how they were going to do it. So they don't have to put IVs, they're not putting blanketrals on people, they're actually just gently shoving a thing up in someone's nose as they're getting CPR. and they're turning it on. And it's a small device. I mean, it's almost like a Zoll, right? Very tiny, easily transportable, and then can get folks to the emergency department. And this particular trial, we see that they did out-of-hospital cardiac arrest. They had to have bystander witnessed arrest. They had to be over 18. The EMS had to respond within 15 minutes to the call, and then there had to be return of spontaneous circulation prior to the initiation of cooling. And so very, very rapid response and initiation out in the field. And then if they were over 80, they couldn't participate. And the trial compared rapid onset cooling versus the standard of care, which is very similar to what we are generally in the ED or up in the ICU when they arrive to the ICU. And so they enrolled 677 patients, quite a large study. For example, the Bernard trial had 77 patients. The HACA trial had 260 patients. Large study, pretty much equally randomized. They had some dropouts for the device didn't work and things of that nature. So in general, they pretty good comparison. And this is the times that they reported. On average, EMS responded and initiated CPR within 9 minutes. They had airway in the field within 14 minutes. They had randomization into the trial within 17 minutes, and they started cooling within 19 minutes. So think about our practices in the hospital. How often do we even get cooling started within 19 minutes of a patient arriving to our ICUs? And this is amazing. So outstanding. What they found in general, just so folks know, that there was really no difference between the two groups in the development of cardiac arrhythmias in the hospital. You know, sometimes that can be seen afterwards. There's no difference in the development of cardiogenic shock. They were pretty equal between both groups. No differences in the development of pulmonary edema, and no differences in the requirement or need for vasopressors. They were all equal across the groups. And we can see in this graph here a clear difference between the control group, which is the standard of care in red, and the very rapid onset of cooling in the intervention group. And they have a time to target 101 minutes versus 182 minutes. So it buys you almost an hour sooner, ultimately, in getting these patients initiated. Now, if we look at the data, their primary outcome was cerebral performance scale at 90 days. And what this is those who survive, do they have no disability whatsoever? They're normal. That's a CPC of 1. Or do they have very mild disability, mild to moderate disability, where they may need to go to outpatient rehab, but otherwise they do well. There isn't an ongoing handicap or whatnot. And if you look at this intervention, in the standard of care group, 13.5% of people had the primary outcome, have very good outcomes, CPC 1 or 2. Whereas the intervention group had 16.6. Okay, so there's a little bit of a difference. That's a non-statistical difference. But if you break it down by rhythm, because they took all comers, regardless of the type of rhythm, or was it shockable or non-shockable, they found that there was a signal in the VFib group that had an initial shockable rhythm of VFib, where in that group there was again, a difference, 34% in the early cooling, almost 35, versus about 26% in the standard of care. Now this too was non-significant, but was close to significance. So all in all, these were some of the celebrated results of the trial, that there's potentially a signal that we can potentially need to divide patients out. Some are responsive to early initiation of cooling, some appear not to be. That makes sense. If someone has a PEA arrest and you don't figure out why they PEA'd, like they may not, and they probably won't recover. So that's something in the field that we think about a lot. they seem to show that early initiation of cooling, the earlier the cooling was initiated, the actual better association with outcomes. So that there may be a point to initiating early cooling. And that all sounds great, until you take a step back for a second. How does this compare to the HACA trial? How does this compare to the Bernard trial? How does this compare to the TTM trial? Because those numbers seem really low. And sure enough, they are. And the next slide will show that. So what we take away from this trial is that we can do excellent, well-designed trials where we can intervene as close to the time of cardiac arrest, and we can do it well. That was demonstrated. That transnasal cooling is safe and allows for a significantly shortened time of onset. So there's a new device we can use. It's always fun to have new devices. That the early initiation does not clearly benefit all patients with out-of-hospital cardiac arrest, but that there may be a signal in certain subgroups, which we don't really parse out at this moment. And so let's compare it to the trials. So the HACA trial and the Bernard trials are over here on the left. Their favorable neurologic outcomes were 55 and 39%. And they used about the same measurements, a CBC of 1 or 2. I went back and double checked. So 55 to 39% CBC 1 or 2 in those two trials. So even the normothermia group had 39% good recovery. In the TTM trial, the 36 versus 33 trial, about 45 to 47% and 44 to 47%. Again, there's no difference between the two, right? Those favorable neurologic outcomes. But in this trial, 16 to 13%. It is severely lower than the standard of care, and even their standard of care was quite low. So what does this mean? Nobody really knows at this point, in part because the trial is still ongoing. What was presented were preliminary results at 90 days, and the paper has not yet come out. So if we think about early cooling, especially out of hospital, and people are talking about we need to do this faster outside, I think we need to hold off for a second to make sure we look at all the data from the trial and to put it into context with the data we have from previous trials, because it actually may be unsafe. And if you go to some meta-analyses from Italy, they've actually demonstrated, not good quality clinical trials like this, but there is this suggestion that early initiation, for some reason, is associated with poor outcomes. No one really knows yet, because if you go to the lab, when I worked in the lab on hypothermia, we started hypothermia immediately, and we had great outcomes. So why is it different in humans? And it's probably because humans are different. We don't know yet, but this is an example of something getting a lot of buzz that maybe we need to take a step back and not run too quickly into changing our standards. And so what does this mean? So there seemed to be a range of effective target temperatures, not just one, 32 to 36. That the time to target temperature may be effective from 0 to 6 hours. 6 hours were, all the other trials generally achieve their target around 6 hours. But moving it forward, we're not at the point where we can do that safely yet. Duration of target temperature management appears to be effective when we sustain it for at least 12 hours, up to 24 and maybe even 48. Recent trials showed there's no difference between 24 and 48 hours, 28 and 48 hours. And there may be subgroups that benefit from very specific targets, such as VFib, VTAC, and so on. Those trials haven't been done yet. That's where I think the future should go. But this does sort of nebulousness does reflect what is suggested in both the AAN, the American Academy of Neurology, and the Neurocritical Care Society guidelines, as well as ILCOR, which is the International Society for Committee on Resuscitation and so on, the AHA, essentially. So where do we need to go from here? Subgroup tests, biomarkers, who benefits from what, and quality measures, which include reducing the variability. And that's kind of what, yeah, here. So what do you figure, what is in your practice the most important factor for cardiac arrest outcomes? Is it the duration? Is it how quickly? Is it temperature, avoiding complications? Where we're at now is certainly we're trying to solve some puzzles. And I think just like this, we're trying to figure out what we want. We are trying to solve some puzzles. We don't know the optimal care. There's no reason right now to deviate from the standard of care post-cardiac arrest. But certainly, moving rapidly into bringing people cool, cold down to 32, 34 degrees very rapidly may be unsafe at this point, and continuing our standards of care is kind of where we're at this point. And I want to raise up avoiding complications, and I think we can move on to the sort of end here. Where we're at now in sort of the care is certainly puzzles are being solved. That's the research process. In the hospital, we have a huge quality issue in terms of picking targets, sticking to targets, moving between targets. I've seen that starting off at 36 and a new attending comes on and then it goes down to 32. And so I think one of the great areas that we can all work on as we're doing research is improving our quality of care that we're providing in the post-arrest situation and coming up with new strategies to actually maximize what we're already doing. Thank you.